Hi, and welcome to On Air with Vyaire, podcasts from the front lines, an educational podcast series featuring discussions with frontline medical experts about their experiences ranging from airway management or the dynamics of recognizing, preparing, and managing patients with COVID-19. At Vyaire, we are truly proud to partner with you on the front lines of the COVID-19 global health crisis. And thank you for the work you're doing to help improve outcomes for patients with COVID-19 around the world. The host of Podcasts from the Front Lines is Vyaire Vice President, Medical Director Michael Pedro, MD. This episode is focused on how severe COVID-19 compares to ARDS and features world-renowned expert in pulmonary rehabilitation, Dr. Franssen. Dr. Franssen is currently a pulmonologist and medical director at CIRO, which is a respiratory center for expertise for chronic respiratory disease. This podcast is for educational purposes only. The scientific exchange content in the podcasts from the front lines may address the off-label use of Vyaire devices and supplies that are the sole responsibility of the device or supplies owner, and is undertaken with the understanding that the owner assumes all liability for such use.
On today's episode, we'll be discussing pulmonary rehabilitation of post-COVID-19 patients and the role of respiratory diagnostics. Joining us today is a world-renowned expert in pulmonary rehabilitation, Dr. Franssen. Dr. Franssen is currently a pulmonologist and medical director at CIRO, which is a center for expertise for chronic respiratory disease. He's also a peer reviewer for multiple international journals, has numerous peer-reviewed publications, and is a fellow for the European Respiratory Society. It's a pleasure to meet you and great to have you on the podcast, Dr. Franssen.
Pleasure is all mine.
So, as an expert in pulmonary rehabilitation, I'm assuming that you've probably seen the impact that COVID-19 has both systemically and specifically on pulmonary function. I'd love to hear what you're seeing, what your experience has been.
Yeah, so following the pandemic of COVID-19, we have transformed our pulmonary rehabilitation center to a center for post-acute COVID-19 care, because we know obviously that these patients, especially the ones that have been hospitalized, are in a very poor physical condition. Not only have they been in bed for quite some time, they have been physically inactive, they have lost physical functioning. Also, a lot of them have lost tremendous amounts of weight. They have muscle weakness and loss of muscle mass. And most of them are hardly able to get out of there. So that's the physical part of it. But in addition to that, we see that a lot of these patients have psychological problems. They are anxious, they are often depressed, and they have, you could call it post-traumatic stress. Sure. And also we see that a lot of them have cognitive impairments, probably resulting from their severe illness. All of them are topics that we can very well address during pulmonary rehabilitation. Among them, of course, is also the impact that this COVID-19 has on their respiratory function. We assume that the disease will have a tremendous impact there, although there have not been a lot of studies addressing this topic. So far, as long as I know, there's only one study in a small population that looked at lung function in COVID-19 patients at the moment of discharge from the hospital. There were around 100 patients in that study, and what they found was that the main impact on lung function was mainly on diffusion capacity. They noticed, for example, that almost half of these subjects had impaired diffusion capacity at the moment of discharge, and that this prevalence was much higher in those that had severe illness. Around 85% of them had a diffusion abnormality. Also, if you look at lung volume, especially the total lung capacity is reduced, occurring in about 25% of those hospitalized, up to almost 48% of those with severe illness. So not so much airflow limitation in terms of reduced FEV1, but mainly diffusion impairment.
Now, is this typically what you see in a normal ARDS or severe ARDS picture, or is this kind of a different pattern?
Yeah, I think that this is what we see in patients that has been hospitalized with severe pneumonia, ARDS, And we must realize that this is short term. This is at the moment of discharge. So it would be really important to know what is the long-term consequences. And obviously we do not know for COVID-19, but we know from ARDS that especially in the first year after discharge, there is a recovery in lung function. Also there, diffusion impairment is the main problem. And especially in the first year, you will see that the diffusion capacity will renormalize up to, let's say, 75% of normal on average. And in the years thereafter, a normalization up to 80% will occur, let's say in general. But obviously there are patients that do not have this recovery and that will have permanent damage, mainly diffusion abnormality, but also fibrosis and restrictive lung function abnormality. And that is obviously what we need to keep in mind if we follow up these patients with COVID-19 for a longer period of time.
At your institution, you currently following patients up and performing lung function tests on these patients?
Yes, we are. Of course, we have to take in mind that for the first period, at least, we have to consider these patients to be contagious. Okay. So we do not perform lung function testing in those that are suspected of disease or those that are acutely ill. We wait for at least 2 weeks. And in the ideal situation, we confirm that they are COVID-19 negative. And then, of course, we take measures to prevent that our coworkers and also other patients will become infected.
Thank you for joining us today. To suggest a topic for future podcasts from the front lines or to stay informed, please visit us at Vyaire.com.